Good afternoon, everyone. My name is Guillaume Nyakaboyi, and today I'll be presenting to you my project entitled Estimation of Dose to the Lung Liver Tumor for the Treatment of Hepatocellular Carcinoma using yttrium-90 microspheres. And before I go on, I would love to extend my gratitude to Colin and Paul from the Department of Nuclear Medicine and Dr. Pageman for this opportunity to undertake this study. So what is hepatocellular carcinoma, so aka HCC? So it's one of the most frequent liver cancer, and it's ranked number 6 most common cancer in the world, and number 3 most leading cause of death due to cancer. The development of it is very, very complex. However, it does occur within an established background of cirrhosis. So if somebody has cirrhosis, they have about 70 to 80% of developing HCC. And as you can see from this figure, so it developed from the inside and move all the way to the surface. Let's just look at statistics back here in Australia. So as of 2019, so about more than 2,000 people actually die from liver cancer, and about more than 2,500 actually going to be diagnosed with liver cancer. So before we head into the treatment or diagnosis of liver cancer, just look a little bit of the anatomy of the liver, because this will actually help us to understand why certain treatments are done. So the liver itself is one of those biggest organs in the body. It's actually made of 2 lobes, right and left, the right having most of the mass and the left just having the remaining. And in terms of the blood supply, so we have 2 vessels, hepatic or portal vein, which bring about 70 to 80% of the blood to the liver. It is nutrient rich, and hepatic artery, which bring about 20 to 30% of the blood to the liver. And something to note here, so most of the tumor within the liver, they actually get their blood supply from hepatic artery. So this is going to be very, very important when we are talking about the treatment that I'm actually going to be researching on. And in terms of segmental anatomy, so the liver can actually be divided into 8 segments. So which means if we take one segment, for example, we were to remove one here, we can still actually have the liver function as it's supposed to be functioning. And the liver is one of those organs that can actually regenerate after resection. So let's just look into the diagnosis of HCC. So the first of all, you can take a blood test. This blood test actually look at the level of this protein, alpha-fetoprotein. So an increase of this protein can actually mean that the person may have HCC. However, some tumors, they actually don't lead to an increase of this protein within the blood. Of course, medical imaging is another way of looking whether somebody have HCC. So ultrasound is the first test that is done when there is a suspicion that the person may have HCC. And the good thing about ultrasound is easy, it's cheap, it does not use any ionizing radiation. And of course, we can use CT and PET for tumor localization, and MRI is another way that we can actually use for diagnosing HCC. And we can also use biopsy. So biopsy would be to check whether it's a malignant tumor or a benign tumor. And of course, there are other ways that we can actually use, such as laparoscopy, where you just put a camera on the surface of the liver and try to see if the person have HCC. So in terms of treatment, so we can have surgery or liver transplant, but the problem with surgery, it is actually limited to stage 1 or sometimes stage 2 liver cancer. So it cannot be applicable for all the stages of HCC. We can have ablation, that's when we use heat, or we can also use cold to actually kill cancer cells. So the ablation actually involves just inserting a needle into where the tumor is and use some sort of radio wave to generate heat, or use some microwave to generate heat. In doing so, you can actually end up killing the cancer. Sometimes you can actually send a high concentration solution of ethanol and kill the cancer. The problem with this method does have some limitation. It can only be used for small cancers, about 3 centimeters. of course, radiation therapy by using external photon beam or proton beam. We can use that one for the treatment. Chemotherapy, use of drugs to kill the cancerous cells within the liver, and of course the radioembolization, which form part of the SERT or selective internal radiotherapy. So this one is the one that I'm actually gonna focus on. So what is SERT? So SERT is actually a form of brachytherapy. It's normally used in interventional radiology. So involve an injection of yttrium-labeled microsphere into the tumor, into the hepatic artery. One of the reasons I said most of the tumor, they actually get their blood supply from hepatic artery, because those microspheres, they're very, very small. They then percolate and get trapped into the tumor vasculature and start irradiating the surrounding tissue and, of course, killing the cancer cells. So traditionally, this method is actually used for palliation. So which means there is actually a need to use this method for curative intent. So the thing that we have to worry about this form of method is the extrahepatic dose deposition. That's the dose that goes outside of the liver, that goes to the lung. That's why my project is a matter of just estimating this dose that goes to the lung. So the treatment planning. So first of all, they use a catheter angiography to visualize where we're going to put the catheter. And then also we have to also identify other vessels from the gastrointestinal tract, so that we actually don't end up putting the catheter there. And also, once we have optimized the catheter position, we can then administer technetium-99 as a surrogate, and then we look at the biodistribution of it. And then once we analyze that, we can actually extract some parameters to actually measure the dose to various organs. So one of the parameters that we look is lung share fraction and the tumor to normal ratio. So once we have all those parameters, then we can apply a few models to predict the dose. So we have empirical model, body surface area-based model, and of course the partition model. So the empirical model just is based on the percentage mass of the tumor. So it can only have a maximum prescribed activity of about 3 gigabecquerel. That's what it can predict. So we can say that it's not really personalized because it does not actually take any patient-specific parameters. And BSA model is a semi-empirical model. The good thing about this one, it does assume that there's a correlation between body surface area and the tumor, but various studies have actually refuted the fact that there is no correlation between body surface area and the tumor. So it's still kind of empirical. However, in clinic, it's still used nowadays. So, and then to calculate the activity, just use the BSA. It will be based on the BSA. So again, this is not personalized because it does not take any patient-specific parameters such as the tumor to normal ratio. So partition model, so this is the one that I'm actually going to try to optimize for my project. So introduce 3 compartments, so the lung, the tumor, and the normal liver. And then the activity, which will be deposited in each compartment, will then be determined by using MED equations. So this model here is much more personalized because it does take patient-specific parameters such as the ratio of the tumor to normal health tissues. So let's just look a little bit on the partition model and see a bit of the limitation of it as well. So the first thing about the partition model as it is used today, it does assume that there is a perfect distribution between technetium-99 and yttrium-90, which is not really the case. So various studies have shown that is not the case. And it also assumes that all the decay energy, everything that we're going to get, is actually going to be deposited into the lung, liver, and the tumor. And the other problem we relate to using this model is when you use planar scintigraphy. So this methodology here does not, which is used in various clinics, it does not actually account for the different attenuation between the liver and the chest. And I'm going to actually, later on, I'm actually going to show if you don't account this attenuation, what will actually end up happening. So there is no anatomical references, which means when you're drawing the region of interest, it is always subject to the operator's bias. and the motion of the patient due to breathing can also complicate the analysis. And the lung of the mass is always, the mass of the lung is always set to 1 kilogram. So it doesn't really calculate the mass for each patient. So how can we find a solution to that? So one of the solutions that we can use SPECT. So the SPECT can actually include attenuation or scatter coefficients. On top of that, the CT image can actually be used to calculate the lung of the mass using density voltometry techniques. One of the issues that we can actually run into using this is the misalignment or misregistration between SPECT and CT because of their inherent different resolution. So I looked into different literature review regarding the partition model and the comparison between various of them. So one of the studies that I looked at was by Bernardini in 2014. So he compared different models. He compared the partition model and body BSA-based model, and also looked at what will happen if you do not account for the attenuation. So the partition model came up the best. It was able to predict the absorbed dose compared to other models. And also, if you do not account for the attenuation, you actually end up overestimating the lung shot fraction, which means actually going to estimate the dose that goes to the lung. And Shafar extend the partition model by including other territories such as the arterial liver territories and compare with this one. And then he found that there was a higher dose in the tumor, which is what we want. And also, he found a reduction of those to the normal tissues. Lopez in 2019 compared, used the partition model or to optimize it, and found that there is, by looking at the mass of the lung, he found that there is a reduction of 56 in terms of the predicted dose and 50% decrease in lung shot fraction. So what will be my study? So my study is a quality control study. So what I'm going to do, I'm actually going to follow the patient, or actually going radioembolization using HM90 in this hospital, and I'm going to acquire the CT, the diagnostic CT. This will be used to measure the mass of the lung, and then I'm also going to use the SPECT to actually be able to extract the parameters that I've talked about to estimate the dose. And of course, I'm going to get a PET CT, which is taken 24 hours after treatment, and this will be used to actually compare the dose between the planning and the post-treatment. So the aim of this study, the first of all, I'm actually going to try to develop a MATLAB code, a Python code, that will be used to estimate the absorbed dose to the tumor liver and lung based on partition model, and a methodology to calculate the mass of the lung using density voltometry, and of course absorbed dose between both treatment and post-treatment, and quantify the error between the predicted dose from planning and post-treatment. The significance of it, as I said before, SET has been used for palliation, so we actually want to extend this methodology into using it for curative intent. This can only happen if we can actually calculate the dose that goes to organ at risk or dose that goes to health tissues. In doing so, we can then allow physicians to actually prescribe optimal activity for curative intent. My research map, so I've divided my project into 3. So one is project development, which include the literature review and learning of appropriate software, which are 3D slicer, which I'm going to use for calculating the mass using CT image, and Olinda, which just to look at the simulation of various pharmaceutics into the body, so biokinetics of different pharmaceutics. And from there, develop a MATLAB code and a methodology to estimate the mass. And the other stage would be just look at the patient data, just analyze them, do some of the symmetry around it. And at the end, I'm going to compare the dose deposition in each data set, and of course quantify the error and look at how significant they are. If they're very significant, then it can lead to a publication. So at this point, the next stage from now will be just to learn appropriate softwares, and from there I'm going to be able to develop a MATLAB code, and then from there carry on the project. So something to note with the project is a quality control study. It's more like just looking at the dose that goes to the lung and liver and tumor for when you are treating hepatocellular carcinoma using yttrium-90. Thank you.
Have you tried any commercial software which is actually they are using to calculate the dose?
I know a few. One is there are a few. There is MIM. MIM that she uses MIM for contouring, but not actually.
There's another one from Marion recently. They have done. I think it's probably clinical as it's released for.
Yeah, because the problem with all of those software, they base their data on med equation, which does not account for the inhomogeneity between the yttrium-90 and the technetium-99. So one of the things that I'm going to do is actually to account for that because it's very different. And from there, I'll be able to at least get a better result compared to what they do now. In fact, at the end, I'm actually going to compare my result with what actually they do here. So that's what I said, it's more like a quality control study where I'm actually compare what they do here and what I'm going to find.
Was it just for the one patient?
No, a lot of patients.
How many patients?
So far, I don't know, but hopefully it's going to be more than 10.
Yeah,
hopefully, so yeah. Because I was talking to Colin as well. He said he might even get some data from Fiona's, so which will increase my, my data sample. So
with, traditionally, you had to assume that the technetium uptake would be very similar to the yttrium uptake.
Yes.
But with your method, you'll be able to verify that, won't you?
Yes. So yeah. So what I'm hoping to do. So as I said, I'm gonna do a lot of simulation. So those simulation, I'm gonna be able to simulate the behavior of yttrium microsphere within the body, and then compare that with the behavior of technetium-99. In that way, I can see how I can account for that inhomogeneity within my code.
Okay.
Yeah.
But of course, if you do 10 patients, you'll be able to look at the PET with the yttrium and the SPECT with the technetium.
Yes, that would.
Yeah. What if it's a very poor relationship between them, or it's highly variable from one patient to the next? What would be the implication of that?
So probably if that happens, that means I'll probably say that the inhomogeneity does not really matter too much. Maybe that may be one of the implication of it, but I'm not quite sure. So I have to see the variability between each patient to another patient to make that inference.
Do you know if there's any retest studies of the technetium uptake, like if they put a needle in, do an injection, and then do that again 2 days later? How variable the lung uptake is?
I haven't. What do you mean by?
So if you do the same test on 2 different days,
I haven't seen any study.
You get the same lung uptake?
I haven't seen any study that does that, but hopefully it will be the same uptake. I'm not quite sure, but I haven't read anything related to that. The only thing that I've seen is that the biodistribution, the uptake is different for yttrium-90 and technetium-99, and it differ greatly. So, yeah, and most of the calculation they don't account for that. Yeah.